are in listen-only mode.
Good afternoon, everybody. This is John Peller with the AIDS Foundation of Chicago, and I'm joined today by Melinda Elwood from Center for Health Law and Policy Innovation at Harvard Law School, and Ann Donnelly with Project Inform. They're going to be helping to field questions, and we are going to be talking about Medicaid expansion today. Just a couple housekeeping bits. Please use the question feature to ask questions. You can also email questions to us. And we're trying a new thing today. You can tweet questions to us. And our Twitter handle is @HIVHealthReform. And so we have two fantastic interns here who are going to be live tweeting the webinar also, which will be fun. And if you're having trouble hearing today, please use your telephone instead of your computer to listen to the audio. So click on the audio tab in your little control panel, and then dial the phone number and access code and PIN you see on your screen. We encourage everybody to download the slides and resources. You can go to HIVHealthReform.org and click on the first post at the top of the page to get the slides, and we have some other resources available there. This is part of the We Can Do It webinar series, which is supported by an educational grant from Janssen Therapeutics, division of Janssen Products LP. Continuing credits are not available. This webinar is not a 101, so there are going to be some topics that we're not going to go too in-depth on. And we are sorry to say that we can't provide state-specific information. We just can't provide details on what's happening in all 26 now states that are expanding Medicaid. We do have an upcoming webinar on strategies for states that are not expanding Medicaid, which is on November 14th, and then we'll have the final webinar in this series on December 12th. We encourage everybody to check out HIVHealthReform.org, and in particular, the recent webinars we've done. We've done about 5 that in the past 2 months that are very relevant for health reform implementation. We have marketplace basics, health reform overviews, and information on getting ready to enroll. So these are all really great resources that you should use, and please share them with your colleagues. Just a note before we get started. Remember that clients don't need to change anything if they're already on Medicaid, if they're already on Medicare, or if they have employer-sponsored health insurance through work. There is an exception for individuals and families who have very expensive employer-based insurance. We're not going to get into that today, but do keep that in mind. Another quick note is that you cannot buy Medigap policies on the marketplace. We got a lot of questions about that. So today we're going to focus on Medicaid expansion. We're going to talk about the overview and context for Medicaid expansion, benefits and drug coverage, some important details, and then go into payer of last resort. So let's dive in. Go ahead. So we've really been fighting for healthcare reform since the beginning of the AIDS epidemic, when what we now know as HIV was first identified in 1981. And we're going to take just a tremendous step forward on January 1st of 2014. But there are going to be problems, and it's not going to be a smooth process. So we need to work together to make health reform a success. And as everybody knows, there are bumps in the road right now. The federal marketplace has had a lot of challenges. On one hand, it shows that there's a lot of demand, but it also we're also learning through media reports that there are some problems with the way the marketplace website was developed. We know the federal government is doing everything they can to work these out. Keep in mind that the real deadline for coverage is early December to apply for coverage that begins January 1. And applications for the marketplace will be open through the end of March. The good news is that state Medicaid enrollment websites seem to be working pretty well. And we know that in most states, the majority of our clients are going to be eligible for Medicaid. Just to give a little context here, we are talking today about Medicaid expansion. The other major part of health reform, which we have done other webinars on, is private insurance marketplaces. We're not going to be covering that today. We're going to be focusing on the Medicaid expansion, but it's important to keep in mind the wider context of healthcare reform, and we'll talk a little bit about how folks can go between Medicaid and the marketplace a little later. So going back to last summer, the Supreme Court ruled on the Affordable Care Act and said that the Affordable Care Act is constitutional. That was great news. They also said, and this is where we have run into many of the challenges we're facing now, that Medicaid expansion is constitutional, but the federal government can't force states to expand Medicaid. And the way the law was written, the federal government was able to withhold payments for regular Medicaid if states didn't expand the whole program. And the Supreme Court ruling said that this was not constitutional. And this makes Medicaid expansion essentially optional for states, which gets us to where we are now. Currently, there are 26 states expanding Medicaid. If you're on the phone today, hopefully you are one of those states. The great news we heard earlier this week on Tuesday evening was that Ohio is expanding Medicaid. And so that makes it the 25th state, obviously a very large state, so adding a really big population, and a very Republican state. John Boehner is from Ohio. And so it's really great to see a Republican state adopting Medicaid expansion, and we hope this will be the first of many. It's important to remember that Medicaid is certainly an imperfect program, and health reform overall is far from perfect too. It's really important to keep in mind that step one is getting people covered. And once we get people covered, we can work to improve the programs and improve the coverage that they're receiving. That's what we have done with the Medicare program over the years. An example of that is adding Part D drug coverage a couple of years ago. There are also provisions that will help to improve the program. And one of those is a temporary increase in payments to primary care providers, which should increase access and improve provider networks. So that is an important way to address some of the gaps in coverage. It is certainly true, though, that as Vice President Biden said, Medicaid really is a BFD for people with HIV. Traditional Medicaid has a cruel disability standard, and under old Medicaid rules, which are still in effect in 24 states, people have to be so sick that they're totally disabled in order to get Medicaid coverage that could have prevented them from being so sick and disabled in the first place. And now in Medicaid expansion states, Medicaid will allow people to have access to a full spectrum of prevention and treatment services that will help them to stay healthy. And this is a really, really big deal. So let's get into some of the details of who is eligible for Medicaid expansion. Medicaid expansion covers childless adults, and this includes parents who may have a child if they're over 18. It could be a married couple who doesn't have children. Medicaid expansion is for individuals 19 through age 64 who are low income, earning below 138% of the federal poverty level. That's $1,321 a month, or $15,586 a year for a single person. We'll talk about the new way that income is calculated, the MAGI, or Modified Adjusted Gross Income Standard, so we'll come back to that. Citizens or qualified immigrants are eligible for expanded Medicaid. Qualified immigrants includes people who, for example, have a green card, who are legal permanent residents who have been here in the country for longer than 5 years. And it is important to check with your state. Some states are covering immigrants who may not be eligible for Medicaid. For example, legal permanent residents who have been here less than 5 years through the marketplace. So there are alternatives there. And in addition, individuals have to be residents of the appropriate state that they're living in. It's really important to know, as we talked about a second ago, there is no more requirement that individuals be disabled to get onto expanded Medicaid. And there is also no more asset tests. Some states have done away with the asset test, but in many states, if you have more than $2,000 for an individual, or God forbid you have a retirement account or some money stashed away in the mattress, in your mattress, you cannot get on Medicaid until you spend that money. So that provision is going away. So what the Medicaid expansion does is creates a new Medicaid door that clients can enter. So currently, low-income seniors can get Medicaid, low-income families can get Medicaid, low-income people with disabilities can get Medicaid, and there's this new door for low-income childless adults that has been opened up. And it's important to know that if individuals' life circumstances change, they can go to one of these other categories. So if somebody, for example, if a woman who is on Medicaid as a childless adult in this expansion category becomes pregnant, she can transition over to coverage for pregnant women. If somebody who is with HIV becomes so sick that they're disabled, they can move over into the category of coverage for people with disabilities. And we'll talk a little bit later about how those benefits may change. Go ahead. Okay, we're going to stop and answer a few questions now. We have a couple that have come in. Just keep in mind that if you're having trouble hearing, you can click on the audio tab, and let's go ahead and take some questions. Anne and Melinda, what do we have? Are you guys there? Did you meet?
Yes, sorry, I just got on. I hope Melinda's here too, and I'm having just a little trouble with some of my, I see what's happened here. Okay, so one of the questions that we have actually refers to traditional Medi-Cal, and people are asking about will spend down remain in place, and I think what they're referring to is the medically needy program in traditional Medi-Cal.
That's correct. And the answer is yes, it will remain in place, but and there are about 16 states, I think, that have a medically needy program. So this, if you're not sure what you're talking about, this may not apply to your state. The spend down program will remain in place, but individuals who are eligible for spend down may be able to get on expanded Medicaid with no spend down. So that's something that individuals should probably get benefit counseling for, but essentially if someone's income before all their medical expenses are deducted is below 138 of poverty, percent of poverty, but above 100% of poverty, so in that window, they will be probably able to get on expanded Medicaid.
That's great, John. And this is Anne again. I just wanted to point out that, as John said, this is a really important question to check in with your state on. I believe there's actually about 30 states that have what's known as the medically needy program. But the thing that you should be checking is how much money you have to pay back to the state, and then also what are the benefits in those different programs. So a really important question to take to a benefits counselor, as John said.
And it looks like we've also gotten a lot of questions about the asset test, and particularly if someone goes from one category to another, for example, from childless adult to low-income family, does the asset test apply? Melinda or Anne, do you know the answer to that?
John, I'm sorry. Could you ask the question again? I apologize.
So do asset tests apply to the to any of the Medicaid categories that are left? Is that a state option?
Traditional Medicaid categories, my understanding is that asset tests will still apply to anyone in traditional Medi-Cal. Or, I'm sorry, Medicaid. That was a California slip.
Okay, but that is going to differ by state. So once again, you are going to need to check with your state to find out what the qualifications are. A couple of folks have asked what the income standard is for families. We're going to be posting a chart for Medicaid, but I encourage everybody to use the search tools at your fingertips. That's good old Google, and search for 138% of FPL for different family sizes, and I guarantee you'll find it. So why don't we go ahead and plow forward here. We're going to touch on benefits and drug coverage. This is where...
John,
go ahead, Ann.
This is Ann. Can I interject one question that I think might be important? This question is, how do eligible people with HIV differ from Medicaid members today? Both in terms, it says cost, but I believe that probably means income and demographics. And I think this actually goes back to that slide that you were explaining before. So maybe we could just have a little bit more information on that.
Ann, do you want to throw out an answer to that?
Sure. I'd be happy to. I think the biggest issue is that as of now, folks with HIV do not have to meet a disability determination in order to get into an expanded Medicaid program. So that's one very big difference. So people do not have to get sick enough in order to meet that category in the new expansion program. The other thing, the new expansion program is set only on people's income. And as John said, anyone making less than 138% of the federal poverty level, which is about, I think, $1,600, $16,000 annually. Is that correct, John?
Yes, that's correct.
Roughly in that area, yes. Everyone below that in a state that is expanding Medicaid will be eligible for Medicaid. There will be no further test of how much money you have saved, your assets, anything like that. It's just based on your income. I think those are the two biggest differences between those with HIV who will qualify and those with HIV who qualified previously to traditional Medicaid.
Great. Thank you for clarifying that, Ann.
Sure.
So we will plow back in here and talk about benefits packages. And this is where things get a little hairy, and it's a little bit of a confusing blend between old and new here. So what states have to do to create Medicaid benefit packages for the expanded Medicaid population is create what's called alternative benefit packages, or ABPs, for the newly eligible populations. And actually, alternative benefit packages have been around for a long time. It's just that not many states have used them. There have been some states that have put them in place for their CHIP program for coverage for children. But they're certainly going to become more of a factor now. And states are able to choose from a couple of existing plans which serve as a benchmark for their new alternative benefit packages. So things like the Federal Employee Health Plan, the State Employee Coverage Plan, or what's called Secretary-approved coverage, which is coverage that the Secretary says, okay, yes, this meets standards. And then states take from the 10 essential health benefits categories, and we'll look at those in a second, to supplement any benefits that are missing from this benchmark plan. And this is essentially the way marketplace plans were put together also. So if you're familiar with the benchmark that was picked for marketplace plans, it's very similar. And the idea here is that new Medicaid, or benefit packages for the new Medicaid population, will mirror to some extent coverage that is available through a qualified health plan on the marketplace. And that is the idea. does seem like a lot of states are trying to essentially put in place their standard Medicaid benefit package as closely as possible. It's difficult for states to administer multiple benefit packages for different populations. So to keep things administratively simple, they're trying to mirror traditional Medicaid as much as possible. One major difference that we are seeing in a lot of states is that there are no long-term care services available through expanded Medicaid. So no home and community-based care, no nursing home care. The reason for that is that we expect the new Medicaid population to be relatively healthy. And if they do get so sick that they may need long-term services and supports, they could go into those old or existing disability coverage categories. So these are the essential health benefits, the 10 essential health benefits that are written into the Affordable Care Act, things like prescription drugs, mental health and substance use, hospitalization, things that are not included that are really important for people with HIV are dental and vision, for example, and we will touch on those in a minute, but those are not essential health benefits. And these mandatory benefits cannot be cut, which is a really good thing, unlike in the traditional Medicaid program. In traditional Medicaid, services like prescription drugs are actually optional, and it is theoretically possible that a state could completely eliminate prescription drug coverage, and folks do threaten that every once in a while. So there are critical services through traditional Medicaid that will now be guaranteed, but only to the new Medicaid population. So what states need to do when they create, sorry, go ahead, Ann.
Sorry, this is Ann. May I interject with a question that's out there?
Please.
Someone asked how many benchmark plans are there? And first of all, I think we want to clarify that we're talking about benchmark plans for Medicaid only at this point, and those are known as alternative benefit plans. And then maybe, John, you want to field that question about how many there are.
So there are 4 plans that states can choose from. It's things like the federal employee benefits, the state employee benefits program, the largest commercial HMO in the state, or what's called secretary-approved coverage. This is where things get really confusing, and it's confusing because there is the other benchmark that's out there that is selected for the marketplace plans, and they're different benchmarks. So don't get lost in the details on this. Just understand that that what states are doing here, and you can see on this chart, is taking the 10 essential health benefits, taking additional Medicaid requirements. For example, family planning services are a mandatory Medicaid service, as is non-emergency transportation, early periodic screening. Those are mandated Medicaid services. So states have to add those in when they're creating their new benefit package. So it's really a mind meld between new Medicaid plus old Medicaid plus the essential health benefits, making sure these 10 categories are covered, and then sprinkle in a little taste of private insurance, stir well, and you have some kind of new benefit plan.
And John, maybe the other important clarification is that while each state has a number of choices, each state will only have one benchmark plan. So it's very important, again, to check in with your state here and see what your state is actually doing about their benchmark plan.
So that's true for the private market, I think, but for Medicaid, states can choose multiple, they may have multiple plans for multiple populations, right, under the alternative benefits.
Thank you. That's a good clarification. Yes.
Sure.
Yes. But each state will have a unique situation that you do need to check with your state. But thank you, Melinda, for that clarification. That's true.
Yeah, sure.
But folks, do keep in mind that at this point, just given the hectic pace of healthcare reform implementation, most states are doing everything they can to keep their new Medicaid benefit package and their old Medicaid benefit package as closely aligned as possible. And we may see down the road that states do different benefit packages for different populations. We really haven't seen a lot of that yet, but it will differ in every state. So let's talk about the medically frail definition, which is an important concept, particularly for people with HIV. The medically frail definition it essentially gives you some individuals in some populations a get-out-of-jail-free card that allows them to go onto traditional Medicaid. And so states can adopt their own definitions of medically frail, but they have to at least include individuals with serious and complex medical conditions, disabilities, a physical, intellectual, or developmental disability, people with serious mental illness and chronic substance abuse disorders. States can include other populations like HIV, chronic hepatitis in their definition. And states are supposed to have a process in place to identify new eligibles who may qualify for the medically frail definition. But not all states are adopting medically frail definitions, at least yet. And so this is really something to watch. All states are going to have a state plan amendment process that under which states have to essentially put their plan out there for review, their alternative benefit plan, their medically frail definition, if they're going to use one, and have a public notice period during which they have to accept and consider comments. So keep a really close eye out for state plan amendments that include these elements and comment on them, because that's really important for everybody to weigh in. Let's talk for a minute about prescription drug coverage in new Medicaid programs.
So, John, before
yes.
we move on, I'm sorry, we've had a question about the process for someone, in quotes, declaring that they're medically frail. So the question was, how does someone declare that they're medically frail? Who is evaluating and making that determination? And is it permanent, or do people have to re-up annually, for example? And I think, and please, my co-presenters definitely chime in here, but I think we're a little this is a very important question, and it's a little bit premature because we don't even know at this point how many states have begun to identify their definition, and they certainly have not begun to identify the process by which that definition will be implemented. At least that's my understanding. However, this is a critical question and really important to watch in your state.
And I think these are exactly the kind of questions that folks need to look at and weigh in on when states come up with their proposed state plan amendments that include these issues. So those are the exact kind of things you need to look for. It particularly, does somebody have the option to choose if they fit the medically frail definition between old Medicaid and new Medicaid? It may be that benefits on one program are better for that individual than others. So those are things to keep in mind.
So I can jump in here for a little bit, too, because I think we have some ideas of what states might be doing. So, for example, we know that in Arkansas, their proposal as part of their Medicaid expansion program, which is actually different than many of the traditional Medicaid expansions, which we'll be talking about, but their proposal, for example, is to have somebody declare themselves eligible, find that they're eligible for Medicaid, and then up on their screen or as part of their application, there will be a questionnaire asking them about certain medical conditions related to the medically frail definition that Arkansas has in place. And so that may be one way that states may choose. So, for example, implementing a questionnaire. I know that in Massachusetts, once you are declared eligible for Medicaid, we will be providing a notice that says, you may be eligible for additional benefits because you are medically frail. Here's how you go about, telling us that you think you may be medically frail. States are also encouraged to use data analysis, so looking at their existing populations and looking at, for example, the number of individuals who have repeated substance use disorder inpatient treatments. And that's just one example. But I think that the question as far as how, again, is something that we really need to monitor. And to your question about whether that could change for an individual, I think the answer is yes. So I think states will vary as far as what they're requiring in terms of individuals identifying themselves as medically frail and then indicating whether they continue to be medically frail. but I've heard some states considering, for example, when they require your recertification, that they may say something about being medically frail at that point. And many states are also thinking about instituting processes, because not only could individuals be on Medicaid and medically frail and then become less needy of those services, it could also go the other way, right? You could be on Medicaid and then become medically frail as your condition worsens. So again, not a lot of details, as John and Ann mentioned, but just some ideas, and again, another really important piece of policy advocacy that needs to continue.
Great. Well, let's keep going here and talk about prescription drugs. And let's just try and well, we're almost at questions here. Prescription drugs in new Medicaid. And this is a really critical area, obviously. Prescription drugs have to meet the benchmark plan prescription coverage standard, and this is the same standard as exists for private plans on the marketplace, and that is they have to provide at least one drug in every USP category, and that's the U.S. Pharmacopoeia category and class, or the same number of drugs in each category and class as the essential health benefits benchmark plan. So this is confusing because they're importing the standard that is used on the marketplace side into Medicaid. And this is a lower standard than what's in traditional Medicaid. And this is something that we commented extensively on when the federal government proposed this, and that we do have concerns about. It's important to keep in mind that this drug coverage standard is just a floor, and many states are probably going to go above this and provide expanded drug coverage. States also have to have procedures in place that allow someone on Medicaid to request clinically appropriate drugs that are not covered by the plan. And so there will be some kind of exception process in place that individuals can follow. It's really critical to find out how that works in every state. It will be different in every state. And there's also very important continuity of care provisions in your state's Medicaid program that you should learn about. So that's things like what happens when somebody switches from one plan to another. Are individuals required to be provided, for example, with 90 days of treatment that they are currently on when they switch over to a new plan? So every state is going to have different provisions in place, and it's important to understand those to advocate for your clients. So let's stop now and take some questions. And Melinda and Ann, how about it?
John, could we step back, and Melinda, could we step back for 1 second? I'm still seeing some confusion between traditional Medi-Cal, or traditional Medicaid programs where the asset test will probably still apply, and the expansion population where the asset test will no longer apply. And so I'm wondering if we can make that clearer for people. And I will need some help from both Melinda and John in order to ensure that we have made that clear. But starting out with an explanation, people who are entering into traditional Medicaid programs, whether it be through disability or through another category, will still be subject to the asset test. People who are going into expansion Medicaid programs will not be subject to that asset test. It will only meet an income test. Does that help to make it any clearer? And Melinda, John, can you think of additional?
That's helpful to me. Of course, every state is going to be different, and some states have eliminated their asset test for the traditional Medicaid population. So, okay, a question that we got is that came in is about where to find the benchmark plans for each state to get an idea of what might be coming. I would say that in most states, as we said, states are going to be following the traditional Medicaid plan. So I think having a good understanding of what your traditional Medicaid benefits are is going to be important, and also identifying, and everybody will know this or should know this, which benefits are most important for people with HIV. Certainly when the state releases its proposed state plan amendment with all of these issues in it, you should be reviewing it to make sure that, in particular, access to prescription drugs is adequate for people with HIV, and make sure that the formulary that the state plans to use includes all of the medications, certainly that are on the standard Medicaid formulary, and if the state has a particularly limited formulary, any others that you think should be added. So that's going to be an important state-by-state issue.
And John, I would say that the addition to that, which is all absolutely correct, is that we all need to be aware of what our state's process, and we need to help them articulate it. Our state's process will be for someone to request a medically necessary or clinically appropriate drug, how long that should take, and what sort of paperwork needs to be filed, so that we're very clear on it. And the same is true with any continuity of care protection. So if someone is currently on a medication and entering a new Medicaid program, what is Medicaid's responsibility to ensure that that person has continuity of care with their medications? And each state, as John said, will differ, so it's really up to us to find out what our state's requirements are and what the process is, so that we can ensure that our clients understand their rights and are able to execute their rights in continuity of care and in access to clinically appropriate medication.
We've gotten a couple questions about what we mean by expanded Medicaid. And by expanded Medicaid, we don't just mean people from 100 to 138% of the federal poverty level. What we are referring to is the new Medicaid category of what we're calling childless adults, even though they may have children, just not in the home, or maybe they're over 18, or married couples, who are eligible only because they are poor. This is the new Medicaid category that is individuals 19 to 64 who are eligible because their income is below 138% of poverty. This was the new door to Medicaid that we talked about all the way on the right. So hope that's helpful.
Yeah, and maybe another way to look at it is with our old Medicaid program, you used to have to both meet income tests and asset tests, but you also had to be part of a category, as John mentioned. You had to be a person with a disability, or you had to be a person with children. For the new expansion program, you no longer have to be a part of a particular category. And, of course, you no longer have to meet that asset test. All you have to do is qualify by income, if that helps to think about it that way.
That's a really critical point, Ann, and most importantly, that people with HIV don't have to be so sick that they're disabled anymore. That's the game changer here that we're talking about. Melinda, anything you would like to weigh in with?
No, I think that's all right.
Okay.
Someone did ask a question, John, about whether there are any data around how many people, and I'm assuming we're talking people with HIV, will be eligible for expansion who are uninsured today versus how many will have commercial insurance. And Melinda, you may be aware of more national data, but I can say that as we've looked at it in the state of California and some other states that I've been in touch with, roughly we expect about 70% of people in California who are currently uninsured to be people with HIV to be eligible for our expansion of Medicaid, and roughly, again, about 30% of people we expect to be eligible for the private marketplace.
And actually, this is something we do have this information posted on HIV Health Reform for a number of states under the state-by-state tab. Melinda's organization, Melinda, you can talk more about this, has done some studies of ADAP and the breakdown of ADAP.
Yes, that's right. So you can actually look at the HIV Health Reform page to see a kind of state-by-state analysis of how many individuals are going to be or that we estimated would be moving from a state's ADAP program to a state's either private market or Medicaid program. But as you probably have heard, this is really going to vary by state, and the reason for that is because every state has different standards of income eligibility that are existing both for ADAP and for Medicaid. So for example, in Massachusetts, we've had a Medicaid waiver for a very long time that actually goes up to 200% of poverty. So the transition is going to be a lot different than the transition in a state like California where they haven't always had such a program. And I think the final piece is that, again, if a state is expanding Medicaid or not, that also makes a difference, clearly. And again, in many states, there are populations of individuals living with HIV who are on Medicaid. They just have qualified through the traditional means of becoming disabled. So again, it will really vary by state, but I encourage you to look at HIV Health Reform to kind of get some idea of those estimates, as well as NASTAD, the National Association of State and Territorial AIDS Directors.
Thank you, Melinda. And again, the website is HIVHealthReform.org. You'll see it on every slide. Just add a .org to the end, and you got it. And on HIVHealthReform.org, it is the state-by-state tab. And we encourage you to dig through that website because there's lots of information there. Anne or Melinda, anything else before we go on?
Nope, I think
I'm sorry. Go ahead, Melinda.
No, I have nothing to add. Go ahead.
Okay. There's one thing I think that I would like to read because I'd like to clarify the question. And it says, does the state of California, but let's just say, does any state have premium subsidy programs in place for a Medi-Cal exchange plan? And the reason I read that is I just want to clarify some things in that question. First of all, Medicaid expansion is very different from the private marketplace. Those are two very separate expansions or coverage expansions, and that's what John explained at the beginning of the webinar by looking at these two strategies by which we expand. Secondly, Medi-Cal could have some costs associated with it. That's a state-by-state option. Where states do have costs associated with their Medi-Cal expansion programs, some states may have additional help for people with HIV through their Ryan White programs. But again, you have to check at your state level to see what your state is planning to do in that regard. And I hope that clarifies a little bit for that question.
Thank you for tackling that one, and that is a very important distinction here. And so let's go back to the slides here, and if we can just plow through here to as much as possible, and then stop for questions at the next break. That would be great. We have a lot to cover. So first of all, let's talk about cost sharing. We've gotten a couple questions about cost sharing in the expanded Medicaid program, and these new cost sharing requirements or standards actually apply to all Medicaid, both old Medicaid and new Medicaid. These were just updated by the federal government in some regulations they released a couple months ago. So you'll see here, and again, this applies to old Medicaid and new Medicaid. These are maximum out-of-pocket costs, so states may put lower out-of-pocket costs in place. They may have no out-of-pocket costs for some cases or for some populations. Again, find out what your state is doing. The old saying is, when you see one Medicaid program, you've seen one Medicaid program, because they are all different. So some examples of what the federal government is allowing is for individuals whose income is below 100% of federal poverty level, the max for inpatient stays would be $75, which is an incredibly high copay, I think. For 100 to 150% of FPL, up to 10% of the stay. For higher income people, up to between 150 to 200% of FPL. would be 20%. So in particular, pay attention to the cost sharing for prescription drugs. Could be $8 for non-preferred drugs, $4 for preferred, up to 20% cost sharing for non-preferred drugs for the higher income folks. These are pretty high copays, although there is a limit of no more than 5% of income on a quarterly or monthly basis. So do find out what your state is doing here, and weigh in if they're proposing what you think are very, very high copays, and make sure the state understands the potential impact on your population. Let's talk a little bit about the enrollment timelines. December 15th is the deadline to apply for coverage by January 1st. We are encouraging people not to wait that long. You should probably apply by December 7th or somewhere in there in order to make sure you have coverage. Do remember, though, that there are no enrollment deadlines for Medicaid, which is different from the marketplace. So open enrollment ends for the marketplace on March 31st of 2014, but Medicaid clients can enroll in Medicaid any time. Remember that Rhine-White payer of last resort requirements apply, so clients should not be waiting to the last minute. They are required to enroll in any coverage that's available. We'll be talking more about payer of last resort a bit later. Do keep in mind that some states have decided very recently to expand Medicaid. An example is Ohio. I don't know when their coverage will start, but chances are they're going to have to make a lot of system changes to put the new Medicaid eligibility standards in place, and that could take a while. So they may expand later in the year. In that case, individuals could continue to rely on the Rhine-White program. Also keep in mind that if somebody is uninsured for longer than 4 months, longer than 3 months, they could be subject to penalties, in particular tax penalties, for being uninsured. So there is that requirement in place that you should keep in mind. So an important concept under new Medicaid is MAGI, Modified Adjusted Gross Income. And we're not talking about those MAGI. This is a different MAGI here. And the idea here is to align Medicaid with the marketplace and the tax system, because marketplace subsidies are based on are a tax-based system. They're a advanced tax credit, kind of like the earned income tax credit. And it's important to make that work to have a standard that is common to both Medicaid and the marketplace to help individuals seamlessly go back and forth between Medicaid and the marketplace when their income changes. And we'll talk about that in a minute. MAGI is adjusted gross income from the tax form plus things like foreign earned income that would typically be excluded from taxes, tax-exempt interest, tax-exempt Social Security income. We have some resources here at the bottom of the page that you should consult for the full list of MAGI standards, and NHELP has an 85-page guide to MAGI, which if you really want to get lost in the weeds, you should certainly look into. Some really important examples of income that is not included is child support, workers' comp, and SSI benefits. So for many of our clients who are on SSI, that is not counted. And it's critical to project income for 2014 using these MAGI standards because there really can be some dramatic changes in income that it's important to get a sense of when a client is applying for Medicaid or for the marketplace. And we'll be sharing a link to a mock MAGI calculator that Illinois ADAP has put in place to help make this make a little more sense. So next, so what if somebody's income changes during the year, which is certainly very likely for folks who are working, particularly around the 138% of poverty line. So if income increases during the year, individuals can ask to be switched onto a marketplace plan, and that is essentially a qualified, it is an exception to the open enrollment period. So individuals get a special enrollment period if their income changes. They will be able to get tax credits and cost sharing assistance depending on what their income is. In addition, if somebody has private insurance through the marketplace and then their income drops below 138% of FPL, so maybe they lose their job, maybe they are have seasonal employment, maybe they work in an ice cream store in the summer and in winter they don't work as many hours, they can call Medicaid and apply for Medicaid. It is important to keep in mind, though, that if somebody was on the marketplace at some point during the year, they should absolutely file taxes because they may get a tax credit for part of the year. So keep that in mind. As people's income changes and they go back and forth between Medicaid and the marketplace, watch for disruptions in care. It's really important to choose a plan that includes the client's current providers, so we're not seeing disruptions. And that's where it's important to understand the state's policies that are in place to protect people during transitions. Go ahead. Next slide. How will clients get medical care? Many states now are placing new enrollees in managed care. And it could be new managed care networks that are being put into place. It could be existing managed care networks. It's going to differ in every state. So find out what your state's doing. In many cases, clients will choose a plan after their Medicaid application is approved. They may have a paper form that they have to fill out to choose their new plan. They may have to go to a client enrollment broker. That is probably going to mirror whatever system is in place now in your state for individuals to choose plans if they're on Medicaid. And again, it's important to choose a plan that includes current providers in the network and covers all their medications. So please keep that in mind. And appeals. This is an important area that we all need to get an understanding of. Sorry for the hokey graphic, but hard to keep things interesting here. Understand the situations in your state under which somebody can appeal eligibility decisions and coverage decisions by Medicaid. And in many cases, if somebody is found ineligible, there may be a benefit to appealing. The state could have made a mistake in determining eligibility. In some states, the federal government may be determining eligibility for your state Medicaid program through the marketplace system, as confusing as that might be. The federal government could have made a mistake too. So know where you can refer clients for help. There may be legal services programs that can assist with appeals. Also know when coverage is denied. For example, if someone can't get the medications that they need, understand the process that somebody has to go through to get coverage for medications. And know the timelines. There are 30-day, 60-day, 90-day timelines that are very, very set in stone, and you have to meet those. Let's also talk about monitoring and enforcing some of the anti-discrimination provisions that are in place. It's really critical that we monitor closely problems that may occur in new Medicaid as well as in the marketplace. This is actually, the monitoring issue is important for both Medicaid and the marketplace. Document what is working and what isn't for people with HIV, and it's critical that we let our federal and state officials hear from us about what the problems are. So it could be contacting your state AIDS director, contacting your state Medicaid agency, letting folks like Ann, Melinda, or me know about problems that you're seeing. Document them in as much detail as possible. and get that information to us. We are going to be putting a system in place on HIVHealthReform.org shortly, we hope, to collect stories. It's also really important to get HIV representatives on state health reform committees. Many states have marketplace consumer advisory committees or Medicaid consumer advisory committees. Make sure that people living with HIV as well as providers are participating in those forums. There are also some new flavors of Medicaid expansion that we're seeing, and some examples of those are in Arkansas and Medicaid. I'm sorry, Arkansas, that's a new state. Arkansas and Iowa. These are states that are doing, instead of expanding Medicaid, they're putting the low-income population into the marketplace with a subsidy and with wraparound services that are paid for by Medicaid. And the reason states are doing this is because it's maybe not politically feasible or politically palatable to expand Medicaid in that state. These are really creative ways to get people coverage, and we should certainly support this type of expansion. But at the same time, there's a lot of questions about how this is actually going to work. And we have to make sure that individuals who are covered have the same rights and protections that people in traditional Medicaid have. Watch for the medically frail opt-out provision, that get-out-of-jail-free card, because that could allow folks to get on traditional Medicaid, which may be more appropriate for some individuals than these new Medicaid provisions. So with that, we're going to stop and take some questions. Ann and Melinda, what do we have?
So John,
one question that somebody pointed out, or just to kind of go back to the cost-sharing piece of Medicaid. So looking at these new cost-sharing options that states have, and again, I want to stress that they're options. States don't have to impose these cost-sharing limits. I do think we want to be aware that there's one piece of that was actually a pretty big win, which is the piece around co-pays for inpatient stays. So previously, state Medicaid plans were permitted to charge up to 50% of the first day of an inpatient stay as a co-pay or cost-sharing piece, and that's now been decreased to only $75 as a max. So I think it's definitely true that that's still going to be a hardship for many people, but I think that is also an advocacy win in some respects.
That's great. Thank you for reminding us about that, Melinda, because that was a major problem.
So John, we have a couple of questions about folks who are dually eligible for both Medicare and Medicaid. And one of the key questions is a person now on Medicare also potentially dual eligible for Medicaid under the expansion? And my understanding of that is that having Medicare means that you do not qualify for the Medicaid expansion. But Melinda, I would love to hear your response on that, because I have not yet confirmed that. I was just asked this question last night, and I wanted to confirm it.
So I'm not sure about the answer to that, and I guess I would say I'd be happy to follow up with folks who answered that, and we can share that. I mean, that's my tentative understanding as well, is that the rules for dual eligibles have not changed, and I'm not sure that it's a per se exclusion from the expansion population. I think that's correct, but let's double check just to make sure, and then we will. But
those individuals would be able to qualify for Medicaid under the existing disability standard. They would essentially go through the existing door to Medicaid, not the new door to Medicaid. Right. And again, this is a question of, kind of what these old Medicaid buckets still exist. I think it's, go ahead.
Right. So no, the answer is correct. So you wouldn't qualify under this new Medicaid expansion population because you are already eligible for Medicare. So that by law disqualifies you from the traditional Medicaid benefits other than the ones that are otherwise available. So for example, if you're on Medicare now, the only reason that you qualify for Medicaid is either A, because you're disabled for a certain period of time, or because you are low-income elderly. And those income limits are still the same as far as getting to be eligible for additional Medicaid wraparound services. And again, when you're eligible for Medicaid in addition to Medicare, you're not eligible for all of the Medicaid services. Some services are certainly provided by Medicare. So the WRAP services, as far as dual eligibles are concerned, are still the same, and they're not affected by this new expansion program.
Great. And we love stump the chump questions. That was one. So when we have to stop and think about something, it's a really good question. So keep those coming.
And another question that came up for folks is in terms of verification of income, and this is something that we've talked about a few times. You know, what happens if somebody hasn't filed taxes over the past few years? What are their options as far as applying, and what do they have to worry about?
So that's a really good question. So that's where the traditional way of submitting documents for Medicaid is still in existence. So individuals will have to provide proof of income, whatever their income is, and it could be a month of pay stubs. It could be whatever documentation you have that shows your income. And that will be accepted by the Medicaid program when you're applying.
So, John, can we also add to that it will be important for people to start filing taxes, however, going into the help in the program you go to does depend on, ultimately depends on your tax verification. I think another very important thing that I'm sorry, I'm not sure if we covered, but your income eligibility is based on your income determination, as John said, either through a standard determination or through the MAGI that we explained. But in addition, it's also based on your accurate projection of your income for the next year. So that's an important thing just to keep in mind. Those two things together are how your eligibility will be determined, or how a client's eligibility will be determined.
Thank you, Ann. And yes, pay stubs will be sufficient, and individuals who get paid by cash, that's where people will have to make a statement of what their income is. Keep in mind, though, that if you are earning cash income, you do need to pay taxes on that. So the reality is there that they're going to need to declare the income that they're earning, and if they're not truthful about that, they're going to be they're going to have to face the consequences. We did get a question about the difference between traditional and expanded Medicaid, and the person said, "I thought Medicaid was Medicaid," and it's a really good question. Medicaid, there's going to be essentially a new Medicaid program that differs in some respects from Medicaid, but at the same time is the same as the old Medicaid program. One of the imperfections in the Affordable Care Act is that states have to put this new Medicaid package in place that really creates some confusion, and it creates confusion for advocates. It's going to create confusion for providers. It's making things harder for states who have to create this new benefit package. So that's a really good point to raise.
I think it's helpful to think about it in this way, right? So Medicaid is Medicaid. It is a single program. This law doesn't change that. But what we're really talking about is how you qualify for Medicaid, and once you qualify, how do the benefits change? So in some sense, Medicaid is correct, particularly in states who are choosing not to institute any kind of changes to Medicaid eligibility. But what the ACA does is say to states, look, you have your traditional Medicaid programs. If you want, you can now include even more people in those programs, and it sort of dictates the types of benefits that they're eligible for. But again, it's the same program. It's just, again, a different way of becoming eligible. And then once you're eligible, depending on how you became eligible, your benefits package may differ. And that has always been true to some degree with Medicaid, but again, we're just sort of adding additional categories, or one additional category through the ACA.
And so can we throw an associated question on eligibility in here, which I think is an important question. Someone asks, how frequently is a person's income verified? For example, if they're on Medicaid and their income goes up, how quickly will the state know this and require the person to get private insurance? And I'm going to start out, and I'd love my colleagues to jump in, but Medicaid sort of certification and application will be an annual application. And the income will be verified on an annual basis. However, the onus, if you will, to report a change of income is really on the client, and it is important if there's been particularly a dramatic change in income for the client to report that as soon as possible so that eligibility can be determined. Is that your understanding, Melinda and John?
Yes, that's my understanding, and there is no penalty for being on Medicaid if your income goes up. So there's no, tax penalty or anything like that. But it could be considered Medicaid fraud if all of a sudden you're earning, $100,000 a year. It's kind of like when you win the lottery, because we're all going to win the lottery at some point. But say somebody becomes a millionaire overnight on the lottery, it's their responsibility to report that, or they could get in trouble for Medicaid fraud. So it is important to report those income changes.
And there's one more associated question that I think is important. Will there be a separate application / process for Medicaid expansion versus traditional Medicaid? And again, I think this, and again, please chime in, Melinda and John, I think this could potentially differ slightly state by state, particularly in the beginning. I think the end result is intended to be that there be one place where people go and can apply for anything. In the beginning, as states roll this out, there may be a slightly different process as to how that goes, how that actually happens. Would that be your understanding, Melinda and John?
Yes, that is my understanding. And in addition, if somebody applies on the federal marketplace, and it turns out that person, once they've submitted their application and everything's been verified, if it turns out that they are in fact eligible for Medicaid, the federal marketplace is supposed to send that file to the state Medicaid program, who is supposed to then accept that person as being eligible for Medicaid. Now, how smooth that process is going to be is anybody's guess. That's the end goal. If somebody thinks that they might be eligible for Medicaid, it's probably a better idea to apply through Medicaid and not rely on the federal computer system to send you over there.
And is it okay to throw in one more eligibility question here?
Sure, yes.
So this question is a very important question for a lot of people. Would couples in same-sex marriages with HIV follow all the rules for income and asset tests to be eligible for expanded Medicaid? I think this is a little bit of an issue in process, and let me throw out my understanding, and Melinda and John, please jump in and correct me if necessary. My understanding on this is that anyone applying for Medicaid, for the marketplace, a newly recognized same-sex marriage will be taken into account in the application. State Medicaids, I believe, have the option as to whether they will take that into account or not. And at this point, at least from the state of California, we are not clear. The state of California will be moving towards taking that into account, but we don't yet have a clear definition of how that will work for this upcoming year in 2014.
Melinda, anything you'd like to add?
No, I think we should move on. We have a little bit more to cover.
Great. Let's do that. Okay, Ryan White payer of last resort. And let's go to the next slide. The Ryan White program is the safety net, and we do need to make sure that it's there for people who have no other options. And this is why we're all familiar with the current payer of last resort requirement. It's something that all of us working in the Ryan White world navigate every day with people who are on Medicaid now, who are on Medicare, private insurance, and in fact about 70% of Ryan White clients have some other form of coverage that the Ryan White program fills in gaps. And the federal law says that the Ryan White funds can't be used for items or services for which payment has been made or can reasonably be expected to be made by another source. And HRSA has said in their Ryan White policy clarifications that grantees have to vigorously pursue enrollment and make every effort to enroll clients in programs for which they are eligible for. And HRSA will probably be doing audits. The Inspector General will be doing audits. So it's important to make sure that you are doing everything possible to enroll individuals in coverage. An important concept, though, is the idea of coverage completion. And Ryan White funds can be used to fill in gaps in other programs. So examples are Medicaid premiums in a state like Arkansas or Iowa, where individuals are going to be charged probably some premium for their marketplace coverage. The Ryan White program could help to pay those costs. Ryan White could help to pay out-of-pocket costs for medications that individuals get through the Medicaid program. Not all states have the capability to do this, however. In addition, Ryan White services that are not covered by Medicaid or private insurance can be covered by Ryan White. So examples are dental. Dental coverage through Medicaid is in many states pretty terrible or will not be available at all to the expanded Medicaid population. The Ryan White program can provide those services. Same with legal services, case management, treatment, adherence counseling, or medically necessary coverage that's limited by Medicaid. An example of that last one is in Illinois, ADAP is now stepping in and covering HIV drugs that Medicaid does not cover. And this is an example of medically necessary coverage that is limited by Medicaid. We encourage everybody to read the policy clarifications that HRSA has put out there on their website, which is hab.hrsa.gov/Affordable Care Act. There's about 6 of them, and they're really not that challenging to get through. So it's also really critical to keep in mind that the Ryan White program is a public health program, and the Ryan White program will and must continue to serve clients who are not enrolled in Medicaid or marketplace plans for whatever reason. We do not want clients to drop out of care. We want to make sure they have access to appropriate high-quality care. And be on the lookout for overly aggressive enforcement of the payer of last resort requirement and challenge denials of care. Make sure you're familiar with HRSA's policies, which, for example, say that if you have made efforts to educate somebody about the requirement that they enroll in Medicaid coverage and you've documented those efforts and the person still fails to enroll, that the Ryan White program could continue to serve them. So that is an important policy to understand. So we're almost at our last slide here, and we're going to leave you with some action steps before we go to questions. And a couple of those, you've seen them throughout the slides, but here they are on one page. Monitor state plan amendments for proposed benefits and drug coverage packages and comment on them. Understand the medically frail definition and comment on it. Make sure you know the appeals process and understand how that works, what the timelines are. And monitor for discrimination and access problems and report those at the state level and at the federal level. So a note about enrollment help. The marketplaces, as well as the federal government, so both the states and the federal government, are putting a lot of money into application assistance programs. So navigators, in-person counselors, they have all kinds of different names. Those individuals who are trained and certified are able to help with Medicaid enrollment, and that is a critical part of their jobs. So if you think that somebody is eligible for Medicaid, you should, depending on what your agency's policies are, help them to enroll yourself or refer them to enrollment assistance outside. And we did a great webinar, if I must say so myself. Thank you, Ann and Melinda. You two did it too. That's all about ways that organizations can prepare for enrollment. And finally, before we take some more questions, here's our contact info. We encourage you to get in touch with us, all three of us at once if you would like. So shoot us an email with questions, and we'll do our best to answer. And we encourage you to download and share the presentation. We'll email you as soon as the webinar recording is available, which should be a couple days. We are doing something new today. We did a pre-post test. So our funders have asked us to measure the increase in knowledge, so what all of you have learned. So we're going to see how those go. So do your best to answer those 5 easy questions. Stay tuned for our next webinar. Here's information about it. And let's use our remaining time for questions. So Ann and Melinda, what do we have?
Sure. So Ann, there are a couple of questions about California, actually. One was, will Ryan White be able to help with the Medi-Cal share of costs?
So my understanding on this is that Ryan White funds are precluded by Medicaid law for paying for share of costs. However, states can use other funds and strategies to help out with that, and currently in California, ADAT does, or the state does help people with HIV with Medi-Cal share of costs.
So just one question for clarification. By share of cost, do you mean cost sharing, or is this something different?
I'm very sorry. I'm presuming, and that's a great clarification, I'm presuming the questioner was talking about Medi-Cal share of cost, which is the amount that you have to pay down in traditional Medicaid in order to be able to access services. And I hope that's what the question was.
That's great. Thank you for clarifying that. John, we also have some questions, just a little bit more of a kind of reinforcement around the relationship between Ryan White and Medicaid, and maybe going back to that slide about what exactly is the obligation of Ryan White programs with regard to thinking about whether or knowing whether someone is Medicaid eligible or marketplace eligible, and sort of their role as payer of last resort.
Yes. Are you? I'm not sure exactly which slide you're referring to, but the HRSA guidance has been very clear, and we can send everybody a link to the policy statement or policy clarification. It might be number 5 or 6. Again, these are on HRSA's website, hab.hrsa.gov/Affordable Care Act. They give the specific example of somebody who has been informed of their that they might be eligible for other coverage, that they have been counseled about how to enroll, that this counseling and provision of information was documented, so you wrote that in the client's chart or whatever record-keeping system you use. HRSA is also very clear that organizations have to have standard operating procedures in place, policies that govern how and when and where and why they're going to inform clients about eligibility for other programs. And if you have done those things, and if somebody refuses or for whatever reason doesn't enroll, you can continue to provide them services. So say somebody is very mentally ill, is homeless, has a substance abuse problem, and they just, no matter what you do, can't get it together to enroll in Medicaid or the marketplace. That's where the Ryan White program's public health imperative comes into place, and where you should be able to continue to serve them. Now, keep in mind here that there is a tension between the Runway program being a public health program and the fact that the Inspector General is going to be looking at programs to make sure that they're doing their job to enroll clients in programs for which they can be eligible. And what we may see is not the Inspector General going and looking at, agencies through an agency's files and saying, so why isn't this person enrolled? They're eligible. But looking and if the most agencies in a community have 95% of their clients enrolled in other coverage, but there's an agency that has 50% of their clients enrolled in other coverage, then that agency may get some additional scrutiny. So keep that in mind, and do everything in your power to get folks to enroll. But the Runway program is a public health program, and our goal is to maximize the health of individuals living with HIV and also to prevent new HIV cases in the community by providing individuals access to medications and supportive services and medical care that will reduce their viral load. Melinda or Ann, do you want to add?
I think that was an excellent explanation, and I just want to add one practical point, which is that we have seen in California with our expansion into Medi-Cal prior to 2014 that there is a different standard, frankly, for Medi-Cal expansion and moving clients into Medi-Cal expansion. Everything that John said is absolutely true, but the level of documentation required to show that the client is not able to maintain that insurance is much likely to be much higher with a Medicaid program than with a private plan in which there's extensive cost sharing and there is very legitimately a cost maintenance issue for the client. So just to be aware that there could be two different standards in practice for a Medicaid expansion versus a private marketplace expansion.
Melinda, any questions that you want to throw out there that you've seen?
There was one question about what you meant, John, by overly aggressive payers of last resort. I'm not sure if you can clarify that.
So there may be agencies out there who decide we're not going to we're going to decide just not to risk it, and we're going to err on the side of if it looks like somebody has other coverage or if it looks like they're eligible but not enrolled for whatever reason, we're just not going to serve them. And that's not what HRSA's policies say. That's not in line with the public health imperative of the program. There may be project officers at HRSA who don't understand HRSA's own guidance and what the HRSA director, Laura Cheever, has said, who may err on the side of saying, this client is not enrolled, you can't serve them. So be aware of that, and be aware that that it's not there's going to be a fuzzy line here that is going to be subject to a lot of interpretation, and it's going to be probably on a case-by-case basis. Anna, Melinda, anything you want to add?
Nope, I think that's good.
Here's a question that I actually do not have the answer to, and I'm wondering, John, if you or Melinda do. The question is, I understand that we have to get proof of residency. Practically, what does this mean?
So I would say that that's going to be the same proof of residency that's now required for Medicaid. And it could be, proving you have a state driver's license, state ID, utility bills, lease, showing, your residence, a phone bill, things like that. That's what's going to be required.
And again, some states may have different policies about this, so I think the best thing to do for folks who have like sort of specific questions like that is look to your state navigators and other folks who can help with this. There are definitely federal standards, but I think again it's just best to talk to your states about this.
So here's a question about outreach and education and assistance. Since the marketplaces are handling the education to the public about the health exchanges, process and services, will there be a similar service available for potential Medicaid recipients? And how will the general public become familiar with what to ask for when applying?
So interestingly enough, I can jump on this too.
Okay.
So we know that all states have to have the navigator programs, right? And because that there is this streamlined application, it's expected that navigators will know something about Medicaid as well because they need to assist with that streamlined application. So there are actually several layers of different kinds of assistance that states can provide as far as outreach and enrollment. The navigators, again, are required in every state, and then the something called certified application counselors are more of an optional program that states can choose to impart, as well as the in-person assisters. Now, interestingly, the final Medicaid rule does not require certified application counselors to assist. That states have enrollment assisters for Medicaid, but it's certainly something that states can do. And again, there should be assistance available through navigators, and most states, or many states, have existing application assistance programs. I don't know, John and Ann, if you have anything to add, or if you had a different.
Yeah, I'll add just a little bit to that. I completely agree with that. I also, it's my understanding that the assisters, once someone does get to an assister, that they do have an obligation to help them with Medi-Cal. I'm sorry, I keep doing that. I sincerely apologize. In California, we call Medicaid Medi-Cal, and I just cannot seem to get over that distinction, so I apologize. The other thing is that there are states who have a separate program to help both outreach, education, and enrollment for potential Medicaid enrollees, and so that's an important thing to check into. But I think in practicality, as we've been talking about throughout this, this is obviously a brand new program. This is obviously a very extensive reform of our healthcare system. And one thing we have heard in California and in other states is that some of the training that's being given out as of yet does not include enough specific information about Medicaid. So this is something we just want to be aware of, and we want to be sure that we are helping our clients find their way to Medicaid expansion program where it exists.
Great. Well, thank you for tackling that one. We are at the end of our time here, so we're going to wrap things up. Ann or Melinda, any closing comments?
No, I think what I want to say is just that this is a confusing process. As John mentioned, there are going to be glitches. But if you're on this webinar, chances are it's because you're in a state that is expanding Medicaid, which is ultimately a really exciting thing. And I think it's incumbent upon us both to be excited about that, but also to ensure, as John mentioned, the numerous advocacy opportunities that are available to ensure it really works well, I think are critical. And the other piece is that we continue to help our colleagues and friends and others in other states who are not so lucky as to be in a state that's expanding, and to make sure that we are also turning our attention towards advocacy in the federal direction for those folks.
So I think Melinda really said it all, and I'll just reiterate a couple of points, which is I think it is critically important to be patient. This will be a bit of a rough road as we move forward, but the end result is a great result. And the flip side of the confusion and some of the frustration I'm sure all of us are feeling right now is that the program is not fully implemented. And our state people and the federal people are very clear that they want our help in making it work. So I think as we help our clients and as we speak out about what we're encountering in appropriate ways, that we have an opportunity to really shape this as well. So that's the, I hope, exciting part of all of this, in addition to the fact that, as Melinda said, we have an incredible opportunity in front of us, and we need to help all of the rest of the people in the country experience this opportunity as well.
Thank you so much, Ann. Thank you, Melinda. Thanks to our webinar helpers here, Sarah, Pretty, and Abigail. please take the brief survey as you leave the webinar. Thanks so much. Have a great day. Bye-bye.